My net is very, very poor. Hello.
Ah.
Hello. I'm very sorry. I'm sending it my Baba. Come on. Disgusting.
Hello all. Good evening all. Welcome to Indian Medical College presentation on normal development and developmental assessment. We will wait for another 5 minutes before we start the session. Thank you.
I'm still trying. Yes, I'm still mailbox. I think it will take a minute. Let's see.
once you mail me, you can just call me. I don't know, it's always there to happen. So I will take another half an hour class. Email you send me, then you just give me a call. I will get once half an hour will start. Okay. Okay. Okay, friends, it looks like there is a small internet connectivity problem with Dr. Nandita madam. So we will wait for another half an hour for madam to be ready with her PowerPoints. Uh, till then, I have a small topic on friends. It looks like I have a small topic on urinary tract infection in children. So let me tell it in a quick manner for another half an hour so that later on you can enjoy the class from Nandita madam. So it's a case, a 5-month-old girl comes to clinic with a 2-day history of a fever and a 1-day history of vomiting. She doesn't have any diarrhea or URI symptoms, but has significantly decreased intake of both solids and liquids. She has no significant medical history. On examination, she has the following vital signs. Temperature is 102.8 degree Fahrenheit, heart rate of 145, respiratory rate 28, saturation 99%. Her examination is unremarkable and you are unable to locate a source of her fever. So she has fever with no other focus, no diarrhea, no URI symptoms. So question is, should this child have urine studies performed? Yes. So any child under the age of 2 with an unexplained fever should be evaluated for urinary tract infection. Urinary tract infection are now the most common occult infection in febrile infants without a source. So any child without any source of fever, you should always suspect UTIs. UTIs in infants are accompanied by non-specific signs and symptoms. They don't have any signs or any symptoms. Only older children have that burning of micturition and polyuria, such symptoms. So next, true or false, UTIs are more common in girls. Is it true or false? Yes, usually it is true that UTIs are common in girls because of the short urethra. So that's in school age. In school age, UTIs are common, about 3 times more common in girls than in boys. However, under the age of 1, UTIs are seen more frequently in boys than girls. This is an important question. Under the age of 1, the UTIs are common in boys than girls. The ratio is approximately 3 to 5 is to 1. And how about circumcised versus uncircumcised? Definitely, uncircumcised are prone for more urinary tract infections. Which urine studies should be obtained? So the child with fever, with no focus, you are suspecting UTI, you should go for urinary routine. So it's a non-specific, but you usually go for urine routine. Then you have a gold standard. The gold standard is urine culture and sensitivity. So I will go for urine routine. So the urine routine has a So in urine routine, it's urine microscopy, and I also have dipstick methods. Dipstick, I look for leukocyte esterase and look for nitrite. So urinary nitrites, leukocyte esterase, and urinary microscopy. But whatever might be, the gold standard is urine culture and sensitivity, but I need some time for the culture and sensitivity to come. Till then, the urine routine, dipstick method, leukocyte esterase, and nitrite is going to help me out. So what is the method of obtaining sample for culture? Usually it is midstream method for adults, but you cannot get a midstream urine culture in children, young children. It's difficult to collect. So ultimately it's either the catheterized specimen or a suprapubic aspirate is the gold standard technique. In older children, you can go for midstream collection, but for Children, younger children, it's going to be either catheterized or suprapubic aspirate. Best will be suprapubic aspirate, but practically it is not feasible. Practically, patients might be worried, their parents might be worried of an invasive procedure. So catheterized specimen is the gold standard. So in adults, it might be midstream collection, but on younger children, it is catheterized specimen or a suprapubic aspirate. So what's your interpretation? The urine analysis of this child has come out as 3+ leukocyte esterase. Nitrates are negative, 20 to 30 WBCs per high power field and 0 to 5 RBCs per high power field. So I would take that since it is 3+ leukocyte esterase, it's going to be positive for infection, and negative nitrates. Negative nitrates, so it is even though one parameter is negative, do not take that as seriously, because for nitrate to nitrate, you need some time for conversion. So in polyuria, then there may not be so much time. So nitrates may be negative, but your WBCs per high power field is more than 5. So it is significant. 3+ leukocyte esterase, so it is significant. And hence we should take it as probable UTI. So, so the most important are leukocyte esterase, nitrate, and the presence of pus cells and bacteriuria. So pyelonephritis versus cystitis. So it's a very important condition, how to differentiate pyelonephritis and cystitis. Cystitis is localized to the bladder infection, whereas pyelonephritis is related to the parenchyma. So in older children, you might have back pain or costovertebral tenderness if you suspect pyelonephritis. However, any young child with a febrile UTI should always be assumed to have pyelonephritis. So in a smaller child who has fever, it is pyelonephritis unless proved otherwise. So how should this child be managed? Does the child require admission? So you are having fever, your urine routine has suggested that there is pus cells and your leukocyte esterase is positive. So how are you going to admit this child or not? So indication for hospitalization, any child who is less than 6 months, so chances of worsening is very high. And if there is a concern of urosepsis, that the child is sick, then you have to admit, or the child is not taking oral medication, child is vomiting, then we can go for admission. Or if your urea creatinine is elevated, then also you have to admit the child. Otherwise, oral antibiotics is good enough. Okay. So oral antibiotics or IV antibiotics, I said already. So if oral intake is good, then I can go for oral antibiotics. If the child is getting admitted because of poor oral intake, less than 1 year, and elevated renal parameters are there, and the child looks sick, I'm going to go for IV antibiotics. What are the antibiotics possible? We should know the flora. It is going to be E. coli. So give antibiotic for E. coli. So it could be oral, means 3rd generation cephalosporin like cefixime or cefpodoxime for 10 to 14 days. And intravenous choice, go for ceftriaxone. And if the child is fine, switch over to oral cephalosporin as early as possible. But the course will be going like 2 to 10 to 14 days, the course will be going. And urine culture for this child has grown 55,000 colony forming unit per ml of Escherichia coli 24 hours after admission. What is the significance? What is the significance of 55,000? So it's a midstream culture. We collected a catheterized sample, remember? So what is significant count? If it is midstream, anything 1 into 10 to the power of 5 or 1 lakh is significant. For a catheterized sample, anything above 50,000 should be considered significant. If it is suprapubic aspiration, any count should be considered as significant. So here, this child is catheterized, so I should take 55,000 as significant. Similarly, now recently criteria has come AAP. If your clinical diagnosis is compatible with UTI, so even in a midstream, 50,000 should be taken as significant. So the counts is, although it's a reference, you should look at the clinical features. If the clinical features look like an UTI, even if it is less than 1 lakh in a midstream, you should take it as significant. and it should be a single organism. What will you do if there is a mixed growth? If there is a mixed growth, suppose you grow E. coli and Klebsiella, I'm not going to treat both the organisms. I'm not going to treat a common antibiotic for both the organisms. I'm going to say that this is contamination. So I'm going to repeat the urine culture sample. So which of the following imaging studies should be obtained in this child? So once you have a suspected UTI, you have started antibiotics. It doesn't end with that. In adults, you treat the UTI, it ends there. But in children, it's not going to end there, because the children may have some congenital abnormalities of the urinary tract, which is going to cause recurrence in the UTI.
I'm in a meeting. I'll call you back in a few minutes, okay? I'll call you back. Bye-bye. I'm coming back. Don't worry. I'll come back.
Okay. So, which of the following imaging studies should be obtained in this child? We should suspect some congenital abnormalities. If there is a UTI in a smaller child, we should always go for an ultrasound to know any hydronephrosis are there. We should go for a DMSA, dimercaptosubcinic acid scan, to know if there is any scarring, and we should go for a voiding cystourethrogram to see whether there is any vesicoureteric reflex. So any child less than 1 year, Indian Academy of Pediatrics says that go for all the 3 tests: renal ultrasound, dimercaptosuccinic acid, and voiding cystourethrogram, DMSA to see whether there is any scarring, renal ultrasound to look for vesicoureteric, to look for hydronephrosis, and voiding cystourethrogram to look for any reflex. But as the child grows older, we need not repeat all the tests. Depending on the scenario, maybe you can start with an ultrasound. Ultrasound finds out any problems, then go for the VC, voiding cystourethrogram, and DMSA accordingly. So the patient's imaging studies have shown that the renal ultrasound, the right kidney is absent, and only the left kidney, which has an hypertrophy. So I'm going to give 2 weeks of antibiotics. Since there is a single kidney and there is hypertrophy and UTI is there, I'm going to do voiding cystourethrogram. And for this child, after 2 weeks of antibiotics, we did voiding cystourethrogram, which showed grade 4 vesicoureteric reflex in the left kidney. So there is vesicoureteric reflex, which means that the urine is going to reflex to the left kidney. So should this child be placed on prophylactic antibiotics? Yes. So there is a principle that small daily dose of an antibiotic will lead to sterilization of the urine, and reflex of the sterile urine is not going to cause much of infection. So we can give the option of antibiotic prophylaxis to the parents if there is evidence of vesicoureteric reflex. Usually VUR subsides spontaneously over 5 to 6 years of age. So we have to give the prophylactic antibiotics for 5 to 6 years of age. Hello?
Yeah, finally I've sent it.
Okay.
Okay, no problem.
Okay, so antibiotic prophylaxis should be considered in every patient with a first-time febrile UTI, and whenever there is evidence of VUR. So VUR is there, give antibiotics, small doses. It will be like just giving a single daily dose till the age of 5 to 6 years. But at that time, usually VUR subsides. At that time, usually VUR subsides. So what antibiotics should be administered for prophylaxis? So we usually go for trimethoprim, sulfamethoxazole, or nitrofurantoin. They are the best prophylactic options. And less than 2 months, we go for cephalexin. We can go for cephalexin. And for this child, in the follow-up, the child is placed on prophylaxis with trimethoprim, sulfamethoxazole, and the child remained infection-free for the next 12 months. And we said already that VUR usually resolves over a period of time. So we gave antibiotic prophylaxis. So the final points which we learned is any child with fever without a focus, always suspect UTI. Go for the urinary routine leukocyte esterase and nitrate to have an idea whether UTI is there or not. Confirmatory will be urinary culture. Do not go for just midstream urine culture for a smaller child. You have to go for either catheterization or suprapubic culture. Catheterization 50,000 is significant. Suprapubic aspirate, any number is significant. And antibiotics, go for E. coli is the common organism, so usually go for cephalosporin. But remember, resistance is on the rise. So either ceftriaxone or oral cefixime can be tried. Then if the child is sick, you have to admit. And it doesn't end there. It doesn't end there for children. Potentially, there might be congenital abnormalities like vesicoureteric reflex. So you have to evaluate for potential congenital abnormalities. So you can go for a less than 1 year child. You can go for ultrasound abdomen, go for DMSA and voiding cystourethrogram. If you have reflex, you can offer the parents about the option of starting prophylactic antibiotics, which may prevent future UTIs, and usually VUR subsides over a period of time. If it doesn't subside or scarring is happening, or in spite of antibiotics it is happening UTI, then it's time to go for surgery and ureteric reimplantation. I think I just bridged for madam. Madam, I'll 2 minutes, ma'am. I'll just check the mail and start the presentation, ma'am.
Thank you, sir. I'm enjoying your presentation.
Thank you, ma'am. Thank you. Yes, ma'am. I got your PowerPoint.
Okay.
Okay, ma'am. You can just say next. I will change the slides for you, ma'am.
Okay. Thank
And
you.
maybe since we have started a bit late, you can finish earlier, ma'am.
Yeah, I'll try to make it a little shorter.
Okay.
And because it might get too heavy. So I start off now. Sorry for the delay on my part. Anyhow, today we will be talking about normal development and development assessment. Now, why have I selected development to start with? In pediatrics, growth and development are two unique things which we don't generally see in any other aspect of medicine. Because in pediatric age group, the child is constantly changing. So today we will take up one of these unique aspects, that is normal development. Next slide, please. Next slide. Yeah. So what are the objectives of today's class? We will know what we mean by development, what are the different domains of development, and get an idea about normal development in an age-wise manner and also domain-wise manner. Next slide. So first we need to know what is development, what we mean by development. Development is basically, could we go on with the slide? Yes, it is basically a process of evolution. A newborn is born who is totally immature, has no control, and he will evolve from immaturity to complete maturity. And thereby he will gain control. Control over what? Control over self and control over the environment. So this, could we go on with the slide, please? Yes, over self and over environment. And in this way, what happens? A continuous process goes on from conception to maturity to attain this development. Next slide. Okay, this is one thing we should mention, that particularly in motor development, it proceeds from cephalocaudal, from above below. Next. This we will talk about regarding the sequence of events when we talk about developmental delay. But the big fact is that the development occurs in the same sequence. What I mean to say is every child learns to sit before he walks. Nobody ever walked before sitting. Though in case of developmental delays, the whole process may be delayed, but the sequence remains the same. Next slide. Now, what is the period of development? When is this child developing? It starts right from conception and continues up to adulthood. Of this, maximum development occurs during the first 3 years of life. which is called the period of early childhood development. And we look at these first 1,000 days from the date of conception to 3 years, which is very, very important for overall development. I have kept these words in red because all across the globe, a lot of work is now going on, focusing on these first 1,000 days and early childhood development. Why? Because again, from conception to start of school, this is a critical window of opportunity where we can provide stimulation, where we can help the child develop, which will be with the child all along his life. So his final development will depend on what is happening during these early days. Next slide, please. Before we go into the developmental milestones, let us take a quick look at the neurobiology of development. What is happening in the brain as the child develops? Now, we all know that the brain grows. It grows at a prolific rate. And a few figures to make you understand how prolific it is. Well, 100 billion neurons, and each neuron producing 15,000 synapses in the first 3 years of life. And this rate of formation of new connections is somewhere 1,000 per second or more than that. So it's going very fast and very rapidly growing, which leads to an overgrowth. Now, if this overgrowth continues, the brain would be growing and growing and it would burst. That is not what happens. So this overgrowth is then sized down as the synapses are pruned. Just like in a garden, if you let a plant grow, it may grow wild and look terrible. But what does a gardener do? Next slide, please. The gardener snaps some of the parts of these branches to give the tree a good shape. That is pruning. The same thing happens to the brain. And which are the branches to be stemmed? Which are the branches to be pruned? That depends on which part of the brain is getting proper stimulation, which is not. The stimulated part grows, the not stimulated part dies out. And this change in the brain that we can bring about is the plasticity or neuroplasticity, which is very evident in a newly developing brain. And all of these are dependent not only on the genetic predisposition, but also on the environment of the child and the experiences that the child goes through. So this gives us an idea about the importance. This picture shows you what I was telling you about pruning. The picture on top, this is about pruning a plant. And in the brain, it's something similar. See, the neurons are increasing till about 2 years, and then there is pruning to give rise to this final adult picture. Next slide. Okay. So all this development is happening. Why? Why does a 6-month-old baby need to develop? Growing in size and shape could have been enough, but no. What is it that the child needs? The child needs to acquire skills, motor skills, which may be gross motor skills and fine motor skills, by which he will gain control over his self. As I told you in the definition, it is first control over the self. Once he has control over his body, an interest is evoked in the surroundings. And it's not just interest. The child learns to explore and analyze the surroundings. Why does he analyze? To relate the surroundings to his own self. Like, I'll give you an example. A small baby is hungry. Then he understands that there is a person around face. That person, whenever I cry, that person comes to me. And he learns to relate that if I can call that person, I will get the food I need. So it is understanding the surrounding and relating to oneself. And through this, gradually the individual gains control over the surroundings. So this is why development helps the person to achieve. Next slide, please. Next slide. So we have already touched upon quite a few domains. What are they? One is gross motor, that is physical activity at the gross level, sitting, standing, walking. Then fine motor, activity of the fine muscles, which will enable the person to do finer work, particularly using the fingers. That will help the individual in dressing and doing daily activities, feeding, writing, arts, everything that way. Then comes personal, social, adaptive. As I was just discussing, On one aspect, which is understanding the self, personal needs. On the other hand, it is understanding the social environment and then adapting to that environment. Like when I'm taking a class and I look at my students, personally, I know what I'm doing. I'm trying to talk loudly. I'm trying to make you understand. Then I'm looking at my environment, my students. Are they awake? Are they irritated? Are they understanding? Depending on that, I will adapt. A student who is falling asleep, I will try to talk with him. A person who is irritating or agitating the class, I would make an arrangement to see that the others are not disturbed. And the person who is listening, I will try to give more to him. So this is my adaptation. This is personal, social, adaptive goes together. Then comes language or communication, which entails receptive language, that is hearing and understanding, and expressive language, verbal and non-verbal. Apart from this, there are two more that we look into. One is emotional development, very important, and cognitive development, that is intelligence, embraces much of what I have already discussed. Next. So a perfect balance of development is required. And how do we go by this? All this, everything doesn't occur at the same time. As we had mentioned earlier, it is the gross motor development which will give stability and um, stability and ability to move. So the gross motor development is most prominent in the first year of life. Then from the later half of the first year comes in the fine motor development, which goes well into the third year of life. Social, cognitive, and speech starts developing from the first year, but it gains momentum from the second year and onwards. With this, we will go into the milestones. Now, I will purposefully not go into enumerating milestones because that huge list is very intimidating. What happens when a lot of milestones, lot of ages, and trying to memorizing it comes to a big zero? We cannot really grasp the philosophy or grasp the story behind it. But if you look at development as a story, it becomes very interesting. So what we will do here is we will just look at a few pictures and try to analyze. See, first of all, we see 4 babies lying down in a supine position. But do the 4 babies look alike? No. Are their level of development the same? No. We can make out from this. What do we see? A 4-week-old baby is lying limp, a little terse. The head is turned to one side, one hand is flexed, and none of this is actually being done voluntarily. Then we come to a 2-month-old baby. This baby is also lying supine flat, but sort of has a little bit of control. He's looking upwards, his hands are held above his head. He has done it voluntarily. 4 months, not only that, he's looking around, he's trying to grasp an object placed in front of him. And the 7-month-old baby here is interested in the surroundings. He's having something in his hand. So his control over self and environment is improving. Next slide, please. The same 4 babies we have placed in a prone position. What do we see? The 4-weeker lying limp. The 2-month-old is also lying flat, but he can momentarily raise his head a little bit and then it falls. I could not capture that in this shot. But the 4-month-old baby can keep his head up. And the 7-month-old is raising his body on his 4 limbs. So there are differences. Next slide. Next slide, please. Yes. Now what do? I pull the babies up, holding their arms. So this is a pull to sit maneuver. And what do I see? The 4-weeker is limp. His head is lagging behind. The 2-month-old, also his head is lagging behind, but again, he could momentarily lift it to the his body plate and then it sags behind. But this 4-month-old baby, this was a 2-monther. The 4-month-old baby, see his head, he is raising his head and he's trying to sit up as we pull him. And this 9-month-old girl is sitting up on her own, no support, nothing. Next slide. Now, all these 4 babies we have put in a sitting position. The 4-weeker folds upon itself like 2 pages of a book, has no control. The 4-month-old baby here, it's not 2 months, it's 4 months. This baby can sit with truncal support or here with support on his hands, and his back is rounded, but he cannot sit on his own. At 7 months, this baby is sitting without a support. Not only that, see, he's trying to hold an object which is at the side. He's trying to pivot around. And at 12 months, sitting comfortably and playing with a lot of things. So with these pictures, we get an idea how things are changing. Now, from the next slide onwards, I will be discussing or mentioning a few milestones for each age. And I will request you to form a mental picture to sort of visualize that child. I will not go into all the milestones that is important to remember, but if you have an idea about how these babies develop or what are the abilities of these babies at different ages, development will automatically fall into place in your brain. Let us go to the next slide. So, and on the left, you will see in blue in all these slides, I have mentioned the domain, but I will not go domain wise. I will link them up together as an individual. So a 4-week-old baby lies in a flex posture, but is supple. There is head lag. In prone position, the legs were extended. The head is just momentarily sustained at the plane of the body. This baby watches the human face. He watches his mother's face, and he may just begin to smile. Next slide. At 8 weeks, what happens? Now he has a social smile. He is looking at the mother, and he can follow an object with his eyes up to 180 degrees. And he learns to listen to voice. When the mother is talking to the baby, he will look at the baby. Next, at 3 months, a little more developed. Now lying supine, now the baby tries to reach out and wave at a toy. He cannot hold a toy, but he'll be waving his hand. Placed prone, the arms are extended and head is a little above the body. Head control is beginning to come, but still there is bobbing. If you make this 3-month-old baby sit, the back will be rounded. The baby who was listening to his mother's voice now listens to music and he starts to vocalize a little bit, sounds like that. 4 months, next slide. Next slide, please. At 4 months, the supine baby, kept supine, now can maintain a symmetrical posture. Till 4 months, it was all dependent on a reflex mechanism, turning the head to one side the limbs would flex, on the other side the limbs would extend. So the baby could not really control his limbs. But at this point, the baby can lie in a symmetrical posture, can bring 2 hands together voluntarily in the middle. And this is the time he can grasp an object, put it in his mouth. So he reaches out and brings to his mouth. He can sit with truncal support. His head is now steady. So he looks around and he learns to laugh aloud. Next slide. We will go on straight to 6 months. At this age, the baby now learns to turn over from supine to prone. And the object that he had learned to hold at 4 months, now he is transferring from one hand to the other. He learns to enjoy a mirror. He's starting babbling, from vocalization of vowels to babbling, blah, 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 using a few consonants in the sounds that he produces. Next, we jump on straight to 8 months. At 8 months, the baby can sit up alone, even without support. And his back is now straight. He can turn to a side on a sitting position to get an object. If we give him a support, he will pull to stand. He can cruise from one furniture to the other. And now that he can sit, he can also see small objects and takes interests in small objects. So he starts poking at small objects like maybe a raisin or puffed rice or something like that, or pellets. He will poke first with a single finger, then with all fingers, which is a raking movement, and gradually his pincer grasp will develop. We'll come to that. What is assisted pincer grasp? He's trying to pick up a small object, but he cannot do it finely like this. What he can do is with ulnar support, taking support over here, he can use all 4 fingers to pick it up. So he'll try to do that. It starts around 8 months. His cognitive development is coming up. He learns at 8 months, a baby knows the permanence, impermanence thing. That is something that is not visible, maybe somewhere. It is not lost forever. This is the time when the baby learns to play peekaboo. This is the time the baby learns to retrieve a toy which has been hidden. This is also the time when the baby will cry and call for his mother when the mother is away, because he now understands being away does not mean being lost forever. Separation anxiety also starts to begin around this age. So these are all social developments, social and cognitive developments. Baby now starts responding to name and a few words with or without meaning, dada, mama, bisyllables start to develop around 8 to 9 months. Next, we go on to 1 year. Now the baby is walking with the hand held. That assisted pincer grasp gradually develops, which was like this, becomes this, and finally this at, he can pick a small thing with 2 fingers at 1 year. He can release an object. If you ask for it, he'll give it to you. He learns to play with a ball. He starts feeding a doll. He points to body parts. So his cognition is improving. And a few words with meaning has also come along. Next slide, please. At 15 months, he's walking alone. He can indicate his desires. The small object that he had picked up, now he puts it into a bottle. Give him a pencil, he will scribble. Give him blocks, he will build towers of 3. He's using more language, a few more words, some words of his own, which has no meaning. So jargon develops. He has emotional development. He learns to hug his parents. He wants to be cuddled. Next, 18 months. Next slide, please. Now he's running stiffly. Those small objects that he had put into a bottle, now he can dump them out. The scribbling that he was doing, now he can imitate a line. He is learning his own activities, learning to feed himself. He can ask for help. And he now knows pictures, learning to identify objects, learning to identify body parts. He's playing with a doll. We go further to 2 years. Next slide. Next slide, please. Now he's running well, so his gross motor is pretty well developed. He can climb on furniture, he can open doors. With this, his exploration starts. And this is the time when he also learns to listen to stories. He is using small sentences of 2 to 3 words. And if another baby comes to him, he enjoys the presence of that baby, though still he cannot really play with that baby. Next slide. So 2.5 years. What is the difference? Now he can draw a line. Now the gross motor part is done. We're going to look into fine motor and cognitive more. He can build towers of 8 blocks. He talks in small sentences and he starts to imitate and pretend. Parallel play with another baby. Or 2 babies sitting together. They're sharing the same toys. They're looking at each other, but they're not playing to the same game. That is parallel play. Next slide, please. Next slide. Yes. So 3 years, now the baby can ride a tricycle. He can draw a circle. From a line, it has become a circle. He can build a bridge. Now he knows his age, knows his sets, talks in full sentences. He tries to tell simple stories. He learns to play simple games and he helps in dressing, undressing. So more of social skills are developing. Next slide. 4 years. This is going on. Now he can draw, if you ask him to draw a person, he will do it. He's starting imaginative play. He learns to tell a story. And at 5 years, we will stop at 5 years. Next slide. Now he knows colors, he can count well, he can recite a rhyme, he can do his own activities. And the main important thing at 5 years is he wants to learn. He's inquisitive and is curious. So this is the flow of events in development. But next slide. With this knowledge, a baby is brought to you. What are you going to do? What happens is, okay, I know what has happened, what can happen, but what is this child doing? How do I analyze that? So there must be a clinical approach to the child. What I would suggest as the simplest way is, as the pictures I showed you, when a baby is lying in front of you, of course, we'll take a history, we'll do the general survey, we'll do the neurological examination. But when we're doing a developmental assessment for any child, to do it in short, simply, we can place the baby in a prone position, observe the baby, tone, position, head and limbs, ventral suspension, all that we can see. Placing the baby in a supine position, I'm talking about small baby. We can again see the posture, whether there's head lag, movement of the arms. Then what do we do from the supine position? We lift the baby up. Next slide. Pull to sit, as I have shown in the pictures. Just to remind you, I've put the same picture here. That will tell me about the stability of the head, the stability of the trunks, the mobility of the trunks and limbs. Then, next slide, I will offer some large objects. What can a baby do with a large object? Follow, grasp, transfer hand to hand, release, and then play hide and seek. All of these I can test depending on the age and depending what I'm expecting. Then for a baby who can sit, I will give some small objects and see whether you can follow it, whether there is this raking movement, pincer grasp, whether you can put it in and out of a bottle and all that. And finally, I will make use of blocks. I can give the baby paper and pencil to see what he can do with it. To start with, it will be scribbling. Then, how much can a baby do? Can the baby draw a line, a circle, an X? That will tell me whether the baby's cognitive development is going as per age. For this, we use a mnemonic: LOX STD, LOX STD. L for line at 2 to 2.5 years, O for circle for 2.5 years, X at 3, a square at 4, a triangle at 5, and a diamond at 6. Very easy to remember. A rattle would be useful to see if the baby can hear, and then we analyze the vocal response. What is the baby doing? Vocalizing, babbling, few words with meaning, without meaning, sentence, story, so on. And the emotional response, starting from social smile right up to peer interaction. What level is the baby at? So these are the things I should have in my mind. But for every child, it is not possible for you to do the whole assessment. And also, everybody does not need to do a detailed assessment. So here, first of all, we need to have an idea about two words: screening and assessment. When we talk about developmental assessment, screening is something which is a quick process of elimination, which can be done at various levels, starting from the mother up to the primary physician, to make out whether a child may have delay or not. So it should be a quick and simple tool to be applied to a big population, just to screen out those which may have a problem. Whereas assessment is a long, in-depth process which needs to be conducted by the developmental specialists. These tools are highly specific. They take time consuming, but it need not be done with all children. Only for those who are screened positive, who are suspected to have a problem. Next slide. So, who does the screening? Only the pediatrician? No. Developmental screening starts right with the mother. The mother does some screening. The health workers, at the peripheral level, they can do a screening. The primary physician or the primary pediatrician, even in his busy clinic, can do some amount of screening. And those who screen positive need to come to the child development team for a detailed assessment. Okay. So what can the parents do? The level of screening are not the same everywhere. For the parents, we expect only 4 things. And sometimes I also tell my students, these are the 4 things you must look at for every patient. Social smile, did it appear at 2 months? Head holding, was it there at 4 months? Sitting alone at 8 months and standing alone at 12 months. Are these 4 there, present or not? That is important. And can the child see, hear and listen? These are the things we look into. Next slide. Now, what can a health worker do? For him or her, a simple tool would be very useful, and the common tool that we use across the country is TDSC, Trivandrum Development Screening Tool, which is the initial one was meant for 0 to 2 years. That is still very much in vogue. It has only 17 activities to be tested. I'll talk about this later. Just to give you a glimpse, I'll come back. Next slide, please. Next slide. Now, what about detailed assessment? What do we do in a detailed assessment? We again make sure that is development normal or not? Is it really developmental delay? Next, if not, if there is developmental delay, which domains are affected and how much? What is the cause of the delay? What is the diagnosis? There must be a particular problem there, the diagnosis. What is the underlying pathology? Is there any comorbidity along with it? Is there any syndrome? all this needs to be looked into. Next slide. So a detailed developmental assessment goes with history taking, general physical examination, neurological examination, developmental assessment part C, and investigations if required. I will not go into details, but in history, remember antenatal, perinatal history is very important. I will only highlight the major points that you must hit on while you're doing a developmental history taking. Family history is important. Some problem may be running in the family. The developmental history and milestones, I'll come to it. How you need to ask. What are the things you will need to ask? The social behavior and play in the baby. Are there any comorbidities like seizures, like weakness? We need to ask about. Next slide. So regarding milestones, there are certain things the mother will definitely tell you. So here are a list of things that we generally ask depending on the age of the child, depending on what you're seeing in the child. Of course, a 6-year-old child who is having difficulty in walking, you would not ask about social smile. If you see that the boy, the 6-year-old is talking well with you and good social interaction, you don't need to start with social smile. So depending with where you are with this child, these are some questions that we would put to the mother. Preference word. I will not go into details. You can get this later on. Okay, next. Coming to the general examination, anthropometry is very important. Are we dealing with growth delay as well, growth falteration, or is there any disproportionate growth? Is there any dysmorphism? It may be a syndrome. Look at the posture, look at the spine. Neurocutaneous markers, are we dealing with a neurocutaneous disorder? And is there eye contact? Next slide, please. Coming to neurological examination, what is important regarding development? Presence of the primitive reflexes and tone. These two are very important. Why is tone important in development? A child who is going to have developmental delay, particular cerebral palsy, in the early months, developmental milestones are very few. See a 4-month-old baby, what developmental milestone would you expect? Head holding? 3 months. Even then, that would not be there. But how do we know that this baby might develop developmental delay? The babies who are in a state of evolution, evolving cerebral palsy, are most prone to have tone abnormalities. So if we can detect the tone abnormality, we will get an idea what sort of problem we are dealing with. So, next slide. Next slide, please. So the method that is adopted is commonly known as Hamilton method. What we do here is we look for the active and passive tone. The Hamilton method is applied generally at 3, 6, 9, and 12 months, though originally it was said that it could be done up to 5 years. It is done when the baby is alert, awake, and in a supine position. We look for the active tone by a pull to sit, whether the muscle tone is normal. Passive tone is assessed by doing the adductor angle, the popliteal angle measurement, and the scarf sign. We don't have time for details, but this is basically measuring the angle on abducting the thighs, the angle that is formed by the two thighs at the symphysis pubis. Popliteal angle is the angle in the popliteal behind the knee when you flex the hip and extend the knee. And scarf sign is you take the hand across to the other shoulder and see if the elbow is crossing the midline or not. So these are indicative of increased or decreased tone. Also, we look for knee jerk and ankle clonus and primitive reflexes, and a scoring is done. That will tell us whether there is an abnormality or not. Next slide, please. Coming to the tools for development. For screening, I have told you about the TDSC, and there is also another one which is a little more elaborate. For detail, we need some tools for detailed assessment. There are some tools for intelligence assessment and some for developmental aberration. So a numerous number of tools are in vogue. We do not need to know all of them at our level. Next slide. But for screening, this tool TDSC, we need to know. What do we see here? We see some black bars. These bars indicate the range, age range, when that particular activity is attained. Like the first one is social smile, and it ranges from around 2 weeks of age to 3.5 months. So a child should develop social smile between this range. And below you see numbers 1 to 24, which indicates the age. It is a very simple process. As I said, there are 17 activities across all 4 domains. Now, when you have a child to examine, you first calculate the corrected age. Up to 2 years, we go by corrected age. That is, if it's a premature baby, we get the EDD and calculate the age accordingly. Then, according to the numbers below, we draw the age line. And then the activities that cross that line and the activities that lie to the left of that line, we test those. If the child fails even one activity to the left of the line, it is screened positive. Next slide. And what are the things that we need to do all this? Very simple. We need a rattle and a bell. We need a torch, a red ring, a small ball, a little doll, a cup, some beads or pellets. Sometimes we use puff rice, and a small bottle, a sheet of paper and crayon and blocks. So this makes a simple development kit which every student should have ready with them for their board rounds as well as for their exams. Next slide. We're almost at the end. DDST or Denver 2 is another screening tool, but this is a much more complicated tool with 54 items across 4 domains separately. We need to know the name, know the appearance of it, but details is not essential at this level. Next slide. For assessment, commonly used tools are, one is DASI, based on Baroda norms. This was devised in India, and the Bailey 3. Both of these are extensive tools. They take a lot of time. Whereas the TDSC takes about 10 minutes to do. These take 1 hour to 2 hours to do. So this is an elaborate tool. Next slide. Now, both of these, Darcy and Bailey, test only up to age 3. Beyond that, the tests are based not on your motor development, but what we are more interested in is the cognitive development. For that, there are certain intelligence tests like the Wechsler test, like the Stanford Binet test. Just know the names. Details are not essential at this level, and these are generally applied by the psychologist to do an IQ assessment or intelligence assessment. I think that is all. Do we have any more slides? I don't think so. So this is in brief about normal development and how we would go into assessed development. Thank you.
Oh, thank you, ma'am. Thank you very much. So it's an elaborate topic actually. So
yes,
a lot of good pictures were there, and it was in detailed. Good, ma'am. Nice presentation. Maybe we can wait another 2 or 3 minutes if students have any doubts.
Yeah, sure.
I will share with you, ma'am.
Oh, sure. Thank you. I'm sorry I took up a lot of time this way and that way.
It was good, ma'am. Good. And till then, tomorrow Thursday we have 3 to 4 interesting topic in anatomy, cerebellum and fourth ventricle by Dr. Soumya Bhattacharya. And 5 to 6 we have a common topic everyone can attend. It's on soft skills for doctors by Dr. P.S. Sharma. And finally, a biochemistry topic on urea cycle by Dr. Sugandhi ma'am, 6:30 to 7:30. And please do share our YouTube channel and Facebook page. It's simple to share. It's www.tinyurl.com/Indian Medical College 2020. And Facebook also www.fb.com/Indian Medical College 2020. So do share our page to all your friends so that they benefit from it. And I think it's fine, ma'am. Many actually watch the video after this, ma'am. We have around 400 subscribers, so they do enjoy it. They find their own time. So the feedback I will share with you, ma'am.
Okay, thank you.
Good to have you, ma'am. So I think the next week we have on abnormal development, no, ma'am.
Okay. Okay.
So we will have a continuation of this topic on abnormal development and next week. Till then, it's good night. Thank you,
Good
ma'am.
night. Thank you so much. And I'll check with my computer. I might change this laptop and see if I can do it better.
It will do
Get
well.
rid of the problems.
No problem.
Okay. Thank you so much.
Thank you.
Bye. Good night.